a particular flavor to this edition as we set to put in motion something that we plan to be also the launching of our next year's new format for the conference, the symposium, which is very much rotating around or hinging on the joining of forces and ideas between RE and naturalistic decision-making communities. So this is in some way an inauguration of this different way of reflecting about real-world problems. So more on what we will be trying to build on towards next year's summer edition of the RE Symposium, which will be the 9th, and the 15th edition of the Naturalistic Decision-Making conference as well. So we will provide everyone with more information on what we're trying to put together, given even the current circumstances, which are obviously quite uncertain. But we're hoping to build on something new and in view of new times as well towards that event. But so for now, we're just considering this as an inauguration, and it's very much presenting in our own facilities some of the work that's been done under naturalistic decision making, and I hope you enjoy it as much as I've been enjoying, at least from our initial engagement. Without further ado, I'll leave just one quick moment, 1 minute to each of the three speakers today to introduce themselves. And then we will move on to Maarten Schraagen to do his first talk, followed by Laura and then Gary. So in that same order, Jan, would you be willing to do your brief introduction?
Yes, thank you, Pedro. My name is Maarten Schraagen. I'm a principal scientist at TNO and I'm professor of applied cognitive psychology at the University of Twente in the Netherlands.
Hi, I'm Laura Militello, and I am representing two companies, Applied Decision Science and Unveil. My background is in naturalist decision-making and studying decision-making in complex environments.
And I'm Gary Klein. I'm a cognitive psychologist. I helped to found the naturalistic decision-making movement back in 1989, and I am the CEO of Shadowbox LLC.
Okay, thank you. And if anyone has any questions, by all means, put them through the chat box as people talk. But we will have time for discussion at the end. If there are too many questions, I will try as much as possible to put them all through. But if too many come through, I'll try to be as clever and intelligent as possible in managing that. So Maarten, the floor is yours.
Thank you, Pedro, and thanks for organizing and hosting this webinar. So this webinar is on naturalistic decision-making and resilience engineering perspectives on the COVID-19 pandemic. That's quite a mouthful. What do these perspectives entail precisely? So let me briefly explain. Naturalistic decision-making, or NDM for short, is a movement that studies expert decision-making in real-life situations, in contrast to laboratory situations using naive participants. The real-life situations studied by NDM researchers are characterized by time pressure, uncertainty, ambiguity, multiple conflicting goals, multiple stakeholders. Resilience engineering studies how to cope with surprise situations such that we can sustain required operations. Now, it's a dynamic process representing positive adaptation to adversity. So how do these perspectives illuminate the COVID-19 pandemic? First, many governments rely on experts in their decision-making process these days. State virologists, rock stars in a matter of a few months. They have become household names in each country. But they themselves acknowledge the lack of scientific evidence for much of their advice. So what is their expert advice based on? Should we just trust the experts? Well, no, it's clear that this monodisciplinary approach based on medical advice only is not sustainable in the long run, and that we need multidisciplinary and even citizen-empowered approaches. Second, the coronavirus presents us with a lot of novelty, uncertainty, and surprise, and we just don't know much about this virus. As our Prime Minister, Mark Rutte, said, we need to take 100% of the decisions based on 50% of the knowledge. Resilience engineering should be able to inform us how to cope with this surprise situation, this pandemic. But should we merely adapt to this adversity? Just dig deep and get on with things? Be tough and hardy? No, it's clear that this individual approach is not sustainable in the long run and that we need comprehensive systems of support. So I just gave two brief answers to two questions based on the perspectives of NDM and resilience engineering. Let me elaborate on those two answers in the rest of this talk. So in order to understand what expertise is, we need to take a step back in time. The classic study of expertise emerged in the early 1970s with the work by Herbert Simon and Bill Chase on expertise in chess. Simon and Chase found that grandmaster chess players could immediately recognize patterns on a chessboard expertise, in their view, was largely pattern recognition. You recognize a familiar pattern, you immediately know what to do. So this immediacy of knowing is also known as intuition. But it is not magical or mysterious intuition, it is merely pattern recognition. It should not be confused with a vague gut feeling, as it is based on a large store of knowledge and experience. Expertise in this classic view is highly domain specific and does not transfer to other domains. So a chess master is not by definition a checkers grandmaster, let alone a Go grandmaster. Now, it is clear that this is not the complete story. When grandmasters play against each other, the situation is entirely different, right? From when they have to play against lesser players, for instance. They each present the other with surprise moves that go beyond the textbook moves. Now, they can't just rely on pattern recognition. Rather, they need to plan and consider alternative moves. The COVID-19 pandemic is like playing against an expert opponent. So the recognition part of expertise is hardly relevant in this case. I am not attributing any intelligence to this virus, mind you. Rather, the virus itself is new. Even the experts don't know how contagious it is, whether we develop immunity and to what extent, why some are more susceptible to others, etc. We are playing an expert opponent in the sense of being confronted with novel situations all the time. We cannot simply rely on pattern recognition. We need to plan and consider alternative moves. Fortunately for us, the classic view of expertise is not a complete story. If it were, we would not be able to rely on experts when they are confronted with surprise situations. all the novelty of the coronavirus does not prevent virologists and epidemiologists from giving advice. Why is that? It shows that experts, apart from their highly domain-specific knowledge, also have acquired lots of general knowledge and general strategies that they can apply. For one thing, a virus, any virus, spreads through particles in the air as well as direct contact. Hence, the experts advised on social distancing measures. This is sound advice, even in the absence of detailed knowledge of the size of the particles involved or the longevity of the virus on surfaces. So general knowledge and general strategies have replaced specific knowledge and strategies in the absence of further scientific evidence. This is why policymakers can make 100% of their decisions based on 50% of the knowledge. And this is also why they are navigating by sight rather than on a fixed compass. Navigating by sight means changing course, looking at how the ship responds to all external effects of wind and current, assessing whether the ship's response meets pre-established criteria, and then expert harbor pilots, for instance, navigate like this. Their advantage is primarily to know when to change course due to their familiarity with the specific environment in which they operate. Take away that environment, so have a Rotterdam harbor pilot operate in the Singapore Straits, for instance, and you take away a lot of their expertise based on pattern recognition. Yet, they would still basically navigate by sight, initiate an action and observe its effect. And they still have general knowledge on how particular classes of ships respond to particular actions. So in that sense, even a Rotterdam harbor pilot operating in Singapore would still perform better than a novice or someone less experienced in navigating. Now, our Prime Minister has also said that he and his cabinet navigate by sight, right? So it means they critically assess the experts' advice, they take a decision on the measures proposed, assess their effects, and then continue or correct. Policymakers are basically harbor pilots controlling their ship of state. The added difficulty is that they are sailing along in a thick fog and their ship is very slow to respond. The fog is so thick because many parameters can only be assessed in hindsight. Indirectly and after a few weeks based on hospital admissions. But if someone is admitted to the hospital, they have been infected a while ago. And the ship is so slow to respond like an oil tanker because it takes a while for measures to have an effect. And also because so many measures are taken at the same time that they may cancel each other out or amplify each other in interaction with unforeseen behavior. So dealing with these added difficulties of fog and a slow ship response, a proven strategy is to implement measures piecemeal. For instance, opening up schools partially and with half the number of pupils at first, or opening up only a small number of nursing homes for visitors and assessing its effects before resorting to opening up all nursing homes within the country. So piecemeal implementation is the same as navigating by small changes in course rather than large ones, with the risk of having to overcorrect. It's a strategy of low-cost probing that has been proven effective in dynamic environments. So far, I have deliberately simplified the problem by comparing policymaking to controlling a ship of state, but a ship nonetheless. The metaphor is overly simplified in that a society is not a ship in the sense of a single entity being controlled and evaluated by simple input parameters. The metaphor may have had some validity in the early stages of the pandemic, when governments primarily controlled on the basis of a small number of medical parameters, such as ICU capacity available, number, right? So these are the parameters that are updated on a daily basis and that we seem to live by. However important they are, they present a partial picture of the complexity that we all need to deal with. This pandemic has huge repercussions for both health and the global economy, as well as for our personal well-being. There is death and massive unemployment, and also resulting poverty, hunger, domestic abuse, and social inequality. Any government finding a way out, designing an exit strategy, will not only need to rely on medical experts, but will also have to take into account other areas of expertise. So multiple stakeholders with sometimes conflicting goals will have to be taken into account. And in order to maintain levels of trust by the general population in the government, governments have to be taken into account and how options have been weighed. But expertise is even broader than that in this pandemic. At some point, we all become experts in ways to reorganize our society. Local situations differ a lot, and governments need to take this into account. There may be differences in demographics, levels of infection, and mentality. At the local level, there is expertise that may be through social media. Deferring to expertise has proven to be a successful strategy for high reliability organizations, and flattening of networks has proven to be a successful strategy for teams in critical situations. Now, at a national level as well, decentralizing decision-making so as to be able to take into account local differences is essential. Citizens, shop owners, restaurant owners, hairdressers, public transport companies, airlines, they're all experts in how to manage social distance in their respective domains. Tapping into this expertise is crucial for tuning solutions to local situations and also for giving local interests a voice. So, what's the take-home message? Expertise is a social phenomenon. Resilience is a network phenomenon. Expertise is distributed broadly and needs to be tapped broadly. In the end, it's all about people and about connecting people and knowledge. And we may not know everything, but we know sufficiently for getting us out of this pandemic. Thank you. And the floor is back to you, Pedro.
Thank you, Jan Maarten. Just for clarification, I mentioned that you could put your questions through the chat box, but there's actually the Q&A feature that you can use for that. So any questions that you want to put to our speakers today, please use the Q&A feature that you can find at the bottom menu of your screen. So because we still don't have any questions coming through, and I'll suggest we leave that to the end, if you all agree. So I'll pass the word then to Laura. Thank you, Jan Maarten, again, and the floor is yours, Laura.
Great, thank you, Pedro. So today I want to talk about 3 challenges for supporting expertise in the context of the COVID crisis. First, I'm going to talk about developing just-in-time scenario-based training for healthcare workers. Then I want to talk about collecting and curating lessons learned from hotspots. And the third topic will be supporting people in assessing credibility. So let me just dive right in and start with this issue of just-in-time distance learning for healthcare workers. So, you know, we're living in a time when healthcare workers need to rapidly acquire new skills. There are evolving signs and symptoms of COVID, evolving treatments, the personal protective equipment that's available and how you use it has been shifting, how to limit exposure to other people in your household, and telemedicine. I have a friend who had a strep throat and was doing a telemedicine visit with her doctor, who asked her to use her iPhone to shine a flashlight in her mouth and then look into the camera. So it's a whole new world in many ways. And so I am seeing in my email and my newsfeed lots of training materials and questions about training materials, and people sharing training materials to deal with many of these issues. And a lot of what I see are PowerPoint presentations or that have some key information in them, or fact sheets, or sometimes even an animation of how to use personal protective equipment. So this is good. It's a kind of fast, easy way to share information. But the NDM research tells us that the learning is going to be stickier and more effective if it's simple, if you just but what does it look like in the waiting room of a clinic or in the emergency department? And how are we going to reconfigure these physical spaces in a hospital to decrease risk? So the real learning happens when you start to think about these guidelines or these rules in the context of actual scenarios. I don't want to imply that the healthcare community doesn't appreciate scenario-based learning. In fact, a lot of health systems have high-fidelity sim facilities that they use routinely to create compelling, innovative training. But it's just not practical in this context. It takes considerable effort and time to create new scenarios, and then you have to bring everyone together to the sim facility, which is also something we're trying to avoid. So I think as people are scrambling and trying to get materials together, they're kind of jettisoning that. And I think that may not be necessary. There may be some creative ways to create just-in-time scenario-based training that can be used remotely. And as NDM researchers, we're constantly trying to find ways to include context, a backstory. We integrate vignettes to illustrate concepts. We use concrete examples to crystallize key points. So I think it's just part of how we think often. And I think in the next talk, Gary Klein is going to tell you about one training approach called Shadowbox that's had a lot of success with primarily text-based training. But I also want to highlight the value of augmented reality for distance learning. My company, Unveil, has been working on using augmented reality to present video realistic cues that are hard to present in other ways. So changes in skin tone, the change in expression on the patient's face, lots of things that are hard to do with a physical mannequin, you can do with augmented reality. So we are currently working with a large academic children's hospital in a big city in the US to develop training for people at rural health centers who don't see as many critical cases. So the learner at the rural setting will be wearing a HoloLens headset, which is like a goggle, and through that they'll see a virtual patient, kind of a hologram. And in this case, they're going to see an infant who is experiencing cardiac arrest during birth. So they'll be able to do an assessment based on this virtual patient. And then there'll be also a mannequin in the room, a physical mannequin, that they can perform critical interventions on. And so that will all happen at this rural setting. And then at the academic medical center, there'll be a neonatologist who can observe that simulation session and remotely provide coaching and feedback. So that's one way to do some really very compelling and immersive training from a distance. So that's one thing I wanted to hit hard, is just the value of using scenarios. A second thing I wanted to talk about is something I'm calling the assessment action pairing principle. So a lot of medical training separates assessment from action. And I think this is mostly for pragmatic reasons. If you are in a classroom, it's easy to share photos, videos, recordings of breath sounds, or even to do this remotely through PowerPoint or a link of some sort. But those are things that are easy to share with a large group. And so that's how assessment training tends to happen. But the actual interventions require hands-on. So that's when people tend to be in that simulator facility and they're working as an individual or a small group, and they're doing chest compressions, hooking up IVs, all kinds of medical procedures on a mannequin. So the training, the learning to assess a patient and then learning to intervene happen at different times. But the NDM research tells us that for experts, these two things are just inextricably linked. Jan Maarten just talked about that, this idea that, you know, experts are able to experience a situation and know what to do. And so that's what we want to start to build in our training. And again, this is not always super straightforward, but there are some ways to do this. So I mentioned the augmented reality, but I think even in a low fidelity way, we can give people paper and pen scenarios and ask them what they think is going on, how they would assess that situation, and what interventions they would do. And I think this will be a lot more powerful than giving them lists of signs and symptoms and lists of interventions. So getting the learner to imagine themselves in that situation and construct their own understanding of the situation and think about what the next steps ought to be might really strengthen the kind of training that people are creating. So just to kind of wrap that up, I think as these health care systems are scrambling to provide training to staff, some of these NDM-based training design principles might be a really valuable resource for just taking those PowerPoints and those fact sheets up a notch. The second topic I want to talk about is capturing lessons learned from hotspots. How do we do this efficiently? How do we curate them? So I think as this virus moves from community to community or region to region, we're all watching. We're looking what can we learn from what just happened? What do we want to do? What do we want to avoid doing if it comes as it moves into our region? But this again is not straightforward. So I saw a YouTube video that was going around of 3 critical care unit physicians from New York, and they were advocating very strongly for a set of treatments that they believed were effective based on their experience, and it was really compelling. They kind of seemed like heroes, like, we have been working day and night, we've seen all these crazy things, and here's what you need to be doing. But then I started thinking, should we all be doing that? Because these 3 people believe that based on their experience. Should we be sharing that with everyone? Should everyone adopt it immediately? So collecting these lessons learned and figuring out how to curate them and make sense of them is a bit of a challenge. But I think the NDM community has some tools that can help. In particular, the cognitive task analysis strategies that we tend to use for our research. This includes knowledge elicitation or interview techniques that are designed to efficiently collect incidents and apply cognitive probes. And so these interview techniques are not designed just to get a record of what that interviewee remembers from the experience, but also how he or she interpreted it, what meaning they took from that experience, what they think the implications are for their practice going forward, and for the larger system. So we have some experience gathering this data in a relatively efficient and robust way. And then we also are routinely working with multidisciplinary teams to analyze these data. So to find a way to kind of systematically review the data available, to identify insights, themes, challenges, contradictions, common misconceptions. And then the third piece is knowledge representation. So especially as we're living this world where new information is available daily, it's important to qualify findings. And I think qualitative researchers are really accustomed to this. So we are invested in characterizing the aspects of the environment that shaped the specific insights we are putting forward. We think about how to represent uncertainty. Often as part of that analytic process, we're identifying questions about the limits of the findings as they exist. So I just want to make the case that there's, you know, I think these methods are really powerful and could be very helpful in this situation. There's precedence for using cognitive task analysis in this way. There are lots of examples using these methods to capture, curate, and represent undocumented knowledge from lots of different healthcare workers, including emergency department physicians, critical care nurses, pararescue jumpers, pharmacists, and lots of other members of the healthcare team. And a common thread in these studies is that collecting stories is not an end unto itself. So it's not enough just to get compelling stories, but you really want to extract themes and insights that'll be useful broadly to a range of healthcare workers and health systems. And I think we have some track record with this. And so that brings me to my third topic, this idea of what information can you trust? How do we support people in assessing credibility? And this is the one that I'm the least certain about, but in some ways it seems like the most important. This pandemic has created a situation in which the safety of the individual is dependent on the behavior of all. And this means that having a shared understanding of what constitutes risky and safe behaviors is really important. But we're living in a world where we're just bombarded with contradictory information about COVID, about its severity, the symptoms, who's most vulnerable, what to do if you believe you have it, how to control the spread, cost benefits of shutting down businesses and social distancing, testing availability, testing validity, on and on and on. I mean, this is every news story, every social media platform. Information is just flying around and it's largely contradictory. And this is all happening at a time in history when there seems to be a lot of skepticism about expertise. So, you know, before this pandemic emerged, people like Gary Klein, Ben Schneiderman, Robert Hoffman, Bob Weers were writing about the war on expertise. Thomas Nichols wrote a book called The Death of Expertise. So I think in some ways this is just exacerbating this issue of what information can we trust, because there's less agreement than there has been at other times about who is trustworthy. So this raises the question, who do people trust? And I know there's a lot of research on the topic of trust, but as I've been thinking and preparing for this talk, my mind went to this study I did with Helen Klein a few years ago on multinational trust. And for this study, we created scenarios that put you in a position in which you had to trust someone. And then we asked questions about what increased your feelings of trust and what decreased them. And there was a social situation and a work situation and a school situation and a stranger situation. So we wanted to explore trust in a lot of different contexts. And so we conducted interviews with students at Wright State University here in Ohio. And Mei Lin conducted the same interviews with students at Sunway University in Malaysia. And Norma Miller conducted those very same interviews with students at Universidad Tecnológica in Panama. And so what did we learn? Well, there are 3 antecedents of trust that were articulated by Meyer and are well researched. So these are benevolence, ability, and integrity. And as you'd expect, these showed up in lots of the transcripts. These are well documented and have been shown to be an important part of trust in lots of different contexts. So that wasn't surprising. But the thing that I've been turning over in my mind is that we found, particularly for US and Malaysian students, so we found that for US and Malaysian students in particular, people found people who are seen as similar to themselves as more trustworthy. So this included physical similarities. And for US students, this extended to similar beliefs and goals and even similar demeanor. So to me, this means that, you know, for many of us on this webinar, we trust scientists, people with degrees, data, and not just degrees, but degrees and experience relevant to the topic at hand. But this is not universal. So in fact, the very elements that suggest credibility to us may evoke suspicion in others. And one important implication of this is that we should think not just about the content of messaging, but also the messenger. So by paying more attention to the sources people find credible, we may be better able to forge some common ground going forward. And I will stop there, and thank you for your attention.
Thank you, Laura. So we have already a few questions coming in, but I'm going to hold on to these and give Gary the word before going into questions. I'm sure more will come up. So Gary, the floor is yours.
Okay, thank you very much, Pedro. I am in the process of trying to share my screen because I've put together a few slides. And let's see, there's one more thing I need to do, which is to swap screens, I think. And can you see my slides, Pedro? Okay, excellent. So thank you for the opportunity to provide a naturalistic decision-making perspective on this. It's always a problem to go last because I'm spending all my time listening to Laura and Jan Maarten and thinking about all the ideas that they've generated. So I'm going to try to build on some of the things that they said, and I'm going to try to suggest a few naturalistic decision-making tools or methods that people might be able to use for helping to manage the pandemic. Jan Maarten alluded to or specifically described some of the features of naturalistic decision-making as shown in this diagram. So he's already covered all of this, and all of these naturalistic decision-making features seem to apply well to COVID-19, except the one at the bottom, which is about experience and expertise. And that's the one that all three of us are concerned about, because that's going to be the sticking point, because expertise doesn't exist in the way that it usually does in the populations we study. And that's the challenge, is the lack of expertise. And it's a challenge for the NDM community, naturalistic decision-making community. Recognition prime decisions that depend on pattern matching, Jan Maarten pointed out, they're not going to be relevant here because we don't have those patterns, and the patterns we have may be misleading. To some extent, we can disseminate expertise. For example, the use of ventilators. In some countries, they said there's a shortage of ventilators, but there's also going to be a shortage of expertise. They're not trivial to apply. So we need to transfer the expertise of healthcare professionals. So that's an operation that we understand. But there's also an additional need to invent expertise, like how do you diagnose COVID-19? There's new symptoms appearing all the time.
Gary,
and so, yes.
Sorry to interrupt you. Can you swap screens, because we're seeing your side of it?
Swap screens again.
Yeah, great. Thank you.
Okay. All right. So there's a need to invent expertise, because we can't just rely on things that we know. We're learning things. We're learning what are the symptoms, and new symptoms are arising. We're discovering how symptoms play out differently in different populations. So this is a voyage of discovery, not just a way of disseminating the expertise that we have. And an additional problem that we have in terms of using expertise is if people suggest ideas to us, I can use plausibility. Does this make sense? And I can use it as long as my mental model is reasonably accurate. But in fact, my mental model is not particularly accurate here, and I think that's true of many in the population. For example, there was a rumor that made the rounds about a month ago. Here's a quick test that you can perform to determine if you have COVID-19, and as you get up in the morning, hold your breath. And if you can hold your breath for 10 seconds, that's a good sign. If you can't, that's a bad sign. Well, that makes a lot of sense, because we know that that COVID-19 affects the respiratory system. And so, yes, okay, that's perfectly plausible, except there's no validity to it. And so the research simply didn't back it up, even though it was plausible. And then we hear that, well, ventilators are, problematic in their own right, but maybe people don't have to be put on ventilators as much as we are, because they can use a technique called pronation, where instead of having patients on their back, put them on their stomach, and that might improve their condition. That makes no sense at all, except that it seems to work. And so at this point, I realize the mental models that we have simply are going to have to catch up to the treatments and to the indicators. And those things are going to happen in parallel. But as it's happening, we're going to have to be inventing expertise. So that's one set of challenges for the NDM community. But there's also challenges for evidence-based medicine community. Because as I watch people trying to make discoveries, I watch healthcare workers who are making discoveries. What are they relying on? They're relying on anecdotes from other healthcare workers, and they're relying on rumors from what's been used in other countries. They're relying on social media. They're improvising, all the things that evidence-based medicine is trying to teach us to avoid. All of these, these are the traits that we want to overcome. These are the ones that are we're desperately putting into practice as we try to invent expertise. So there's a real mismatch to the strictures of evidence-based medicine and the mindset that discourages individuals for engaging in speculative thinking, saying, okay, just look at the data, look at the double-blind research. Well, we don't have time for doing double-blind experiments. We're having to rely on things like anecdotes and social media, and not uncritically. So that's part of the challenge here. There's an additional challenge to the resilience engineering community. And the question I have is, you can examine an organization or an entity and see whether it's showing up well in terms of resilience, in terms of its structures, but what about the expertise of the leaders and the staff? Surely that counts for something. It's not simply having a resilient structure if you don't have people who are implementing it, who have their own expertise about the domain, which is right now in short supply, and expertise about how to make rapid discoveries, which is also not in huge supply. So these are some of the challenges that we're all facing right now. And I have some suggestions about what we can do for rapid growth of expertise, which is needed at the individual, the team, and the organizational levels. So what about constructing expertise? Laura has already talked about cognitive task analysis methods, about looking at hotspots and trying to talk to outliers and what's called positive deviants and see what they've learned and how we can use cognitive task analysis methods to find out about the tacit knowledge that they're acquiring. And I know that others, George Podorowski and colleagues, have prepared healthcare staff to do their own streamlined cognitive task analysis methods. So that's one possibility. Another way of constructing expertise is something that is called a pre-mortem method that we developed a while ago. And the way the pre-mortem method works is you have your team that's getting ready to implement a course of action, and you say, okay, here's our course of action. We're all ready to get started. Time is wasting, but just a second. Let's not plunge into action here. Let's imagine that we put this into practice and it's a fiasco. And so we know that it's a fiasco. The crystal ball shows us it's a fiasco. Everybody generate the reasons why it failed, and then we consolidate the lists and go from there. And the pre-mortem method turns out to be very effective in terms of helping people with anticipatory thinking. So it's a way of supporting anticipatory thinking in a new type of domain. It's very effective in terms of creating a culture of humility, because now you're learning that it's okay in your team, in your organization, to surface problems that you see rather than trying to keep them quiet because you don't want to disrupt the harmony. And it's also very effective for a collaborative learning, so that you're essentially learning from everybody in the room, everybody in the discussion. The things that they see can now be collected. So that's a second method that I would suggest that might be useful. A third method has to do with the fact that we're dealing with wicked problems. And wicked problems aren't problems that allow true false solutions, but there may be some solutions that are better than others. There's no test about what's a good solution. The goals are incomplete, changing, sometimes contradictory. And an example would be managing the COVID-19 pandemic. One approach that we've developed for trying in NDM for trying to handle wicked problems is something we call management by discovery. And the notion of management by discovery is that as you identify your goals, you want to pursue them. But as you pursue the goals, you have to expect that you're going to revise them. Because if it's a wicked problem, you can't say, I'm going to pin down the goals first before I go further, because then you'll never get started. You have to start with what you know, but you also not only have to prepare to revise the goals, you have to expect to revise the goals. You have to want to revise the goals. And that's a change in mindset for most organizations that want to pin down the goals and just move from there. It's a change in mindset from holding fast to the goals and finding better ways to pursue them, to seeking and expecting and wanting to revise or replace those goals based on what we learn, based on how we reframe the situation. And a fourth method that I would suggest is appointing discovery teams. Sometimes these are called innovation teams. This isn't just a frill, something that's nice to have in addition to the regular staff. And it doesn't necessarily have to be a new position, but some people should be tasked with being on these teams to harvest the expertise within the unit as people are having experiences, noticing things that they didn't expect, making their own discoveries, and as people are getting using social media and other kinds of platforms to be able to rapidly harvest what's learned and disseminate those, because we're in a stage now of rapidly trying to invent and construct expertise, because so many things are novel about COVID-19. Second is about applying expertise. And for applying expertise, one suggestion that I have is a technique called the cognitive tutorial that Shane Mueller and I wrote about back in 2011. And the problem here is that you have decision makers at state and local levels, and Jan Maarten talked about the local levels. They have to apply statistical models and computer simulations. Okay, they know they have to do that, but they also don't understand those models. They don't understand what are the assumptions that are behind the models, what are the limitations of the models, are there ways to work around those limitations, and how do you tailor the models to fit the local conditions. And so the idea of a cognitive tutorial is to provide supports for people to apply these kinds of techniques at a local level for individuals and for organizations, so that they can get a better sense of how the technologies work and how they don't work. And then finally, disseminating expertise. As we acquire expertise, how do you rapidly disseminate it? And the technique that I'd like to surface for you is a technique called shadow box. And that was developed because subject matter experts are costly. They're often unavailable. And here, the expertise itself is emerging. It's emerging rapidly. And so the way shadow box works is you present a complex scenario with decision points. The trainee ranks the alternatives for that decision point, records why they ranked it that way, and then compares the responses and rationale to a panel of experts. And so this is a way for trainees to see the world through the eyes of the experts without the experts being there. And there's a variety of forms of shadow box. It's in a paper and pencil form, but it's also an electronic form, which is very useful when we don't want people to come in contact with each other. So this supports distance learning. And there's a format for scenarios. There's a snapshot version, which is useful for shifting mindsets. And I see one of questions was about changing mindsets and mental models, and also about a cue detect version to train perceptual cues. So the core of NDM is expertise. That's a challenge from the COVID-19, and there's a variety of tools that we're suggesting for constructing expertise, applying it, and disseminating it. Okay, over to you, Pedro.
Thank you. I'm already hearing a virtual clap to the three of you through the chat box. There was someone wishing that we could applaud your insights. So something to take back to Zoom as a future possibility. So we already have quite a few questions. I would go straight into those. So we've got one from Andy Ellis, which I think is more to Jan Maarten, but I think would address to the three of you. A lot of people who are in decision-making positions probably don't see their decision-making processes as being affected by the stress of COVID-19. What techniques have you found useful in getting people to understand that their own mental models are compromised?
Do you want me to take that up, Pedro, first?
Well, I think it was mainly addressed to you, so
yeah, I'm fine. Good. Yeah, that I think. Well, just to be brief, one of the techniques is collaborative cross-checking. That means that people need to check on each other. I think it's basically impossible for someone to see for themselves that their own mental model is compromised in a way. That takes a lot of cognitive capacity. And in my experience, what is always the most useful is to have other people tell you that your mental model or knowledge or whatever is in some way limited. So there are many techniques. Collaborative cross-checking is one of them. But we need teams and we need other people to tell us that our rationality is bounded, so to speak.
I suggest a couple of other techniques. That's an important one, Jan Maarten. One is that it might be possible to start to identify common mental model flaws, so that you can see where people are likely to be confused, and where you may need to proactively make corrections. And then one way to make the corrections, and Laura talked about scenario-based training, is to provide scenarios that illustrate to people the limitations and the problems with their mental model. So as they try to apply their mental model, they see that it doesn't work. And I think Leah DeBello has pointed out the importance of disabusing people of their mental model before they're ready to adopt a different one. So you have to give them a chance to try out a mental model, see its inadequacies, and then let them help lead them to a more accurate one.
Okay, thank you. Another question from Ian Phillips, sorry. Again, this is mostly directed to Jan, but I think it fits well the scope of the three talks. So it's but Jan, you mentioned citizens' engagement as well as utilizing multidisciplinary expertise. And could you speak to the interaction of mass sense making with expertise? Does one inform the other in linear relationship, replace in certain circumstances, augment?
Yeah, so that's important, the interaction of mass sense making with expertise. So, I mean, the general public gets messages from the experts and are partly influenced by that, but of course they also have their own opinions. So what needs to be distinguished here is that it's not just a matter of experts deciding. In fact, I mean, the experts don't decide at a high level. It's the government that decides, and the experts advise. And for instance, we've seen in the Netherlands a couple of examples in which the experts advised something, but then the government, on the basis of some kind of general sentiment in the population, decided something else. So for instance, like a month ago when they wanted to open up the schools or have the schools remain open, the experts said, well, that's okay, there is no problem as far as we are concerned, but the general population was very much against that, and the government decided to close down the schools temporarily. So it's definitely not linear, and it's definitely, you know, it's definitely going back and forth all the time. But we need to remember that it's the task of the politicians and the decision makers to take the decisions, and the experts in this case only provide advice. And of course, the government can then also take into account other opinions than just expert advice, which may sometimes be necessary.
Thank you, Jan Maarten.
So I would suggest a couple, some additional approaches. One, that experts not simply say, here's what I'm recommending, but provide a very short, crisp rationale for what assumptions they're making, and not all their assumptions, because that gets ridiculous, but just what's the basis for their recommendation. And I think one problem that we all worry about is what happens when the experts don't agree with each other. And Laura pointed out the war on expertise, and does that encourage people to stop believing in trusting the experts? And you should never just trust the experts, but I think it's healthy to have experts with different viewpoints and be able to explicate where they're coming from, and give us an opportunity to try different approaches and see how they work out.
Thank you, Gary. Laura, anything to add on this one?
No, I don't have anything more.
Okay. So we have a question from Marco Valente to the three of you. How to assess the level of risk staying away from catastrophe, I mean, in the sense of staying away from catastrophic events in conditions of uncertainty and opacity of knowledge. How do we assess risk?
Well, as I said, you can assess risk. It's hard to, to assess it in advance in all cases. But one thing that you could do is like what the strategy that I suggested is low-cost probing or piecemeal implementation. So what you actually do is you think that by having certain measures being applied piecemeal, so having schools only close, partially or open partially again, you can assess the risk and you can see what happens. So rather than taking kind of a wholesale approach and just opening everything again, it's a piecemeal strategy that allows you to assess risk properly, which is really, I think, the best strategy that we have in these cases of limited knowledge and dynamic situations.
And I would suggest that maybe there are better ways to communicate risk. I think often risk is communicated using various types of probabilities, and people don't speak the language of probabilities very well. And I think about the work of Gerd Gigerenzer, for example, using frequency data to make it clearer to people what the risk categories were, and maybe create those kinds of tables for different samples or different populations, so that they can do a better job of assessing the personal risks that they're exposed to. Right.
Thank you. Laura, this is for you specifically from Jacob Relander. You spoke about using virtual reality and alternate reality as a way to train individuals who cannot experience the training in person. Have you and your team explored gamification concepts to increase retention and intuitive response using the virtual scenarios?
So I have looked into this concept of gamification, and I have in my reading of the literature, it's a little bit diffuse to know to understand exactly what is meant by that. but a lot of the things I have read about, like setting up leaderboards to create some sense of competition, and to insert some playfulness, to increase engagement. Some of those seem not very appropriate when you're training folks who are very serious and dealing with a very serious situation. So for the kinds of training we have created so far, we have not worked to include a lot of gamification. There's one exception, and this is some work I was doing, not in healthcare, but developing training for combat search and rescue pilots. And this we did leverage a game, a kind of first person flying helicopter game, and we created shadow box scenarios, and stopped the gameplay to ask questions. And for that, we did try to incorporate some of the gamification, because the Air Force's goal was to develop training that people would want to kind of do on their own time. And so I think the context matters, how well that gamification aligns with the goals of the game. But I'm not an expert on gamification, so there may be aspects of this I haven't considered.
Right. So we will try to get these questions answered offline as much as possible, as we're coming up to the end of time. Laura, one more for you from Ian Phillips. What will you suggest, or what can be done to reduce the incidence of unintentional blindness when conducting interviews? In example, not seeing what the interviewer didn't expect to see.
Yeah, this is a great question. I find myself on a lot of multidisciplinary teams, and I think there is real value in having, more than one interviewer in the room. We often, immediately after a day of interviews, try to sit down and just jot down what are the interesting things we heard today, so that people can spur each other's curiosity. We often, after we've done some set of interviews, have a larger team review those and think about what questions we're not asking that we should. And it's not at all unusual when I do an interview and I list the most important things I heard or read there, or I heard there, and have a physician read the same interview transcript and pull out different things. So I think, I just think having more people touch and think about that data and having some exchange about what's interesting is one way to just maintain that kind of open mind and sense of discovery.
Thank you. All right, so we're past that time. I will put one last question to the three of you. Well, this is more to Gary, but I think again it applies to the three of you. So expertise probably is also dynamic, changing and growing to adapt to the unexplained, unknown situation. How would you see Shadowbox in preparing experts to go back to high performance situations after COVID-19? Safety sensitive positions. Well, I guess that's the question mostly. It's very much related to Shadowbox, but I think the key point is expertise probably is also dynamic, and I think we can take that for certain. How would you use Shadowbox in preparing experts to go back to high performance situations after crises such as COVID-19?
Okay, so I think one of the important lessons that will probably be learned from COVID-19 is that we can't have a simple model of expertise, that there is expertise, it exists, and the job of the community is to make it available and to change that mindset. And so I think Shadowbox will come into play here to put people in these kinds of situations to break down that mindset and make them realize the brittleness of that mindset, and realize the importance of looking for discoveries, looking for anomalies, looking for things that they didn't expect. We talked about inattentional blindness, and just picking up on anomalies rather than explaining them away.
Can I add to that? I think one of the strengths of these incident-based approaches to training is you create a training scenario, and then you can change certain variables and have the same core scenario, and it's a whole new experience. So we certainly could have a certain challenge and have it occur in the context of all the safety procedures you need during this COVID crisis, and we could present that very same challenge and have it in a you know, I don't know that we'll fall back to exactly where we were before, but whatever the future looks like. So we can just tweak some of those variables and ask many of the very same questions, get some experts to respond to that, and update the training to deal with this dynamic world.
Well, thank you. I'm sorry, we're past the time, but there's one more question that was hanging here from Katie Driver about decentralizing decision making, particularly to you, Jan Maarten. She's asking how can this decentralization be achieved, in particularly avoiding accusations of some kind of postcode lottery, and B, enable practice and ideas to be shared and learned from. So I think this summarizes quite a bit of the three talks today.
Yeah. So by decentralizing decision-making, I mean using all the expertise that is available at local levels, and that expertise is particularly relevant at the stage when certain very practical issues have to be addressed. I don't necessarily mean that, I mean, all decision-making needs to be decentralized. That's obviously not possible. So there needs to be some kind of central kind of global goal that needs to be made explicit and transparent by some sort of government agency. But then, given that goal, the expertise and the authority to implement the measures within the constraints provided by the government around that goal needs to be decentralized. So it's like what the military call mission command, for instance. So it's not something new, but it's a combination of centralization at a higher global level versus decentralization of specific implementation measures.
Right. Well, thank you. Anything to add from any of the three of you? Ari, Laura? No? Well, we're past the time, so in fairness to those who can't stay on, and so we will try, if you agree, I'll try to pass the questions that were still pending here, pass them on to you by email, and if you want to address them, then you please feel free to do so. I would thank very much the three of you for giving us this insightful 1 hour period. And thank everyone who joined us and participated. And I'll leave you a brief teaser for the next talk, which is coming on May 25 on the COVID-19 series, which will be we will be having with you Marcos Borges from Spain and Simon Gill from the UK. We're still trying to close some of the details of this next webinar, but keep an eye out on our website and correspondence. This will be coming out soon for May 25. Thank you again, everyone, and hope to see you all soon face to face.